Well, hi, I'm Steve Ansell, and I'm from Mayo Clinic. I'm one of the lymphoma physicians at Mayo, and it's my privilege to be talking about available and novel and emerging therapies that are specific for non-Hodgkin lymphoma. Firstly, I'd just like to say that we would do this in three groups. We're going to talk about diffuse large B-cell lymphoma, then about follicular lymphoma, and subsequently about new updates in mantle cell lymphoma. A very exciting time in each of these particular diseases. So firstly, to focus on diffuse large B-cell lymphoma. Many would know that the POLARIX study specifically has explored the use of polatuzumab vedotin, an antibody drug conjugate, in combination with R-CHP chemotherapy, omitting vincristine, and comparing that in a head-to-head comparison to R-CHOP chemotherapy. The study initially showed that there was a significant benefit to the use of polatuzumab vedotin plus R-CHP as regards the progression-free survival. And recent data now has looked at the ongoing benefit with now 5 years of follow-up. So shown in this Kaplan-Meier curve, one can see that patients receiving polatuzumab R-CHP at the 5-year mark, approximately 65% of patients remain in remission compared to patients receiving R-CHOP chemotherapy, where that is 59%. So the benefit of the use of polatuzumab vedotin plus R-CHP chemotherapy that was initially seen at the 2-year mark has been updated and shown to be still true at 5 years. Additionally, subgroup analysis has shown that the benefit for the addition of polatuzumab vedotin appears predominantly in the ABC subtype. So if one casts your eye down to far at the bottom of this table, you can see the nanostring cell of origin, and you can see that the ABC subtype benefited substantially in this analysis. Now, I have to stress that this analysis was ad hoc. It was not a primary endpoint of the study, but I do think that's informative as we think about where this agent is probably best utilized. Additional data that was recently presented was to see if the outcomes are still maintained with additional patients added. So a further cohort of 130 patients, a Chinese cohort, was added to the analysis. This obviously allowed for a more global perspective and furthermore enriched the cohort for more patients with the ABC subtype. Again, you can see the maintained benefit for patients by progression-free survival analysis. However, not quite yet a statistical significance as far as overall survival is concerned. You can see, though, that as the longer time is passing, there is a suggestion that possibly a benefit for polatuzumab R-CHP may be seen later on as far as overall survival is concerned. This is challenging to show, particularly in Europe and the US, because of subsequent therapies with CAR T cells and other treatments, but potentially in China and other countries where those agents and combinations are not as easily and readily available, that might be where the bigger difference for overall survival could be seen. The second thing to talk about in diffuse large B-cell lymphoma is now moving from first-line therapy where polatuzumab has made a difference, now right down to what to do after patients have failed second-line treatment. So as shown in this algorithm, many patients who fail frontline treatment are considered for CAR T cells if they fail early, or potentially even for an autologous stem cell transplant. But shown in the circle, there is a sizable group of patients where either they are not eligible for that therapy or they receive that therapy and subsequently progress. So data to share now is those investigational and novel agents used post-CAR and post-transplant and to see how effective they are with longer-term follow-up. So the first agent to mention here is tafasitamab. Tafasitamab, as you would remember, is a CD19 antibody and is utilized in combination with lenalidomide. Again, promising initial data, now showing 5-year efficacy. And I think the encouraging takeaway here is that the overall response rate in this patient population was 57% with a CR rate of 41%. Data showing that the progression-free survival was almost a year. But I think what is interesting for me as one looks at this Kaplan-Meier curve is that you can see if you receive this agent as the first line of subsequent therapy compared to second or subsequent lines, you can see a significant increase in benefit the earlier in the disease course the patient receives the agent. Also really interesting to me is to see that there is a degree of plateau to these curves. Now looking out to 5 years, one can see that approximately a third of patients continue to benefit, and all of these patients actually have remained on the drug until progression, showing that you can administer this drug over time and a subset of patients continue to benefit. A second agent in the same space to discuss is loncastuximab tesirine. This is an antibody drug conjugate targeting CD19 with a PBD dimer attached to it, delivering a cytotoxic agent in a targeted way to the tumor cells. And in this study, again, long-term efficacy being confirmed, 145 patients were treated and almost half of the patients having an objective response, approximately a quarter of them achieving a complete remission. But as we have longer-term follow-up now, you can see that the progression-free survival, while the median is only around 5 months, you can see that a subset of patients continue to have very durable long-term remissions. Particularly if you had a complete response to treatment, the blue line at the top shows a real benefit for those patients, and the benefit appears to be very durable. A second antibody drug conjugate, brentuximab vedotin, is well known to many. It's been used predominantly in T-cell and lymphomas and Hodgkin lymphoma. But here it was utilized in combination with lenalidomide and rituximab, the R-squared regimen, and it was compared to the R-squared regimen with placebo. So in the study in patients with relapsed and refractory diffuse large B-cell lymphoma, 230 patients were randomized to those two arms. I think this was a very surprising and encouraging result. The first you could see is that the progression-free survival was substantially better for patients receiving brentuximab vedotin plus lenalidomide and rituximab at 4.2 months compared to 2.6 months for just lenalidomide and rituximab. But even more interesting, as shown on the right, is that there was an impact seen on overall survival, with a 14-month overall survival when brentuximab was added to the combination compared to 8.5 months. And this has resulted in this agent being approved in this indication. What was further interesting was that expression of CD30 was not really correlated with benefit. Benefit was seen where the CD30 could easily be detected or not. So again, I think this is a very encouraging and interesting result seen in the Echelon 3 trial. I want to move now to follicular lymphoma. So again, just to level set and remind ourselves as to how we typically manage follicular lymphoma. New patients diagnosed with follicular lymphoma, we would utilize FLIPI scores, stage of disease, the symptoms, and whether or not the patient was symptomatic, as well as patient preferences, to stratify patients really into 3 groups of patients. Those who have very low burden and low risk, who can be observed, patients with really mild symptoms who would be treated with an antibody therapy such as rituximab, and then the group of patients which we will focus on in the next few slides, which are the high tumor burden patients, many of whom will receive bendamustine plus rituximab or even R-CHOP chemotherapy. Furthermore, data is showing that lenalidomide plus rituximab R-squared is also effective in these patients. So in relapsed patients who now progress after that strategy, a phase 3 study was presented in the past year. This was a comparison of taking lenalidomide plus rituximab and building on it by adding the CD19 antibody we discussed earlier, tafasitamab, in a combination approach. And that was compared to the R-squared, which was really the standard arm. And in the study, the main points were progression-free survival and long-term outcome. Initially, just looking at response rates, you can see the overall response rate increased when tafasitamab was added. It was 84% compared to 72% when it was just rituximab and lenalidomide, and that was significantly different. But when one looked also at the progression-free survival, you could see that it had significantly increased. Lenalidomide plus rituximab resulted in a median progression-free survival of just over a year at 14 months. Patients receiving tafasitamab plus lenalidomide and rituximab, that was almost 2 years at 22.4 months, a significant improvement. Again, encouraging to see that patients could remain on these therapies over a significant period of time with ongoing durable benefit. And the second agent to discuss in this relapsed and refractory patients with follicular lymphoma, again, is the loncastuximab tesirine, reminding you that that's the CD19 antibody drug conjugate. And in this study, small study, but with very promising results, 39 patients were treated. Important to see that the response rate after 12 weeks was around 67%, but at longer follow-up, that response rate increased all the way to 97%, and many of the patients retaining a complete response when treated. And that resulted in progression-free survival and overall survival curves that looked extremely encouraging. You can see here that although the follow-up is fairly short at only 12 months, you can see progression-free survival here of 95%. Obviously, overall survival was also high, but that for follicular lymphoma is not very surprising, as patients can remain in remission or remain in reasonable health despite progression for an extended period of time. So the third group where probably the greatest changes and findings have occurred is mantle cell lymphoma. So again, just wanted to level set and remind us as to what had been, in many respects, the standard approach for mantle cell lymphoma, and then share some data that has really kind of challenged our thinking and is moving the field in a very different direction. So pretty much 5 years ago, one would have considered a mantle cell lymphoma patient really in two categories: a young patient, less than 65, and an older patient, greater than 65. And then you would always factor in fitness as to whether the patient was fit or unfit. So that would obviously impact both groups. But the patients that were young, the strategy was in general to use a dose-intense regimen, many people using R-CHOP alternating with R-DHAP, or high-dose cytarabine-containing regimens as an intense initial therapy, and then consolidate that with an autologous stem cell transplant, followed typically thereafter with a maintenance rituximab. In an elderly patient for whom a high-dose therapy approach may be challenging, a more moderate chemotherapy approach such as R-CHOP chemotherapy or bendamustine plus rituximab would typically be used, and then rituximab maintenance administered thereafter. For patients who were significantly compromised, one would try a lower dose type of approach of bendamustine plus rituximab, or even just simply a rituximab best supportive care kind of approach. And then thereafter, novel agents would be potentially considered. A number of clinical trials have been reported in the past year that have substantially challenged how we need to think about mantle cell lymphoma. The first of these is the Triangle study. So this was a study done in Europe, which, as you can see in Arm A, took exactly that standard we just discussed, R-CHOP with R-DHAP, 3 cycles of each. Patients then went to an autologous stem cell transplant and were thereafter observed, and depending on the country, could receive rituximab maintenance. That was then compared to the use of adding a BTK inhibitor. So ibrutinib was the BTK inhibitor utilized in the study. Ibrutinib was added to each of the cycles of R-CHOP. Patients went to a transplant, but then received ibrutinib maintenance with or without rituximab, and that was in the second arm. The third arm took it to even a further step, where the transplant was entirely omitted. So patients received ibrutinib along with R-CHOP and then alternating with R-DHAP as the induction, simply went straight to maintenance with ibrutinib with or without rituximab. Again, just reminding you that patients were younger, they had to be 65 and younger. So the data from this trial were extremely interesting. Group A are the standard folks receiving standard chemotherapy and an autologous transplant, followed by observation with rituximab. And you can see that is the red line in the first of the curves on the left-hand side. Group A plus I are the patients for whom ibrutinib was added to the regimen, but who still received an autologous transplant. And you can see that patients had a significantly better outcome when ibrutinib, the BTK inhibitor, was added to this therapy. On the right was an even more interesting result, and that is when one compares the group that did not receive an autologous stem cell transplant, the blue line, you can see that a very similar benefit was seen, suggesting that the role of autologous transplant as consolidation in patients with mantle cell lymphoma, if a BTK inhibitor is part of the induction and subsequently as consolidation and maintenance, whether a transplant is needed. The second study that was interesting was then addressing the elderly patients. So these are the patients over 65 years of age. And as I pointed out on the previous slide, these are patients for whom bendamustine plus rituximab would be a standard of care. And you can see in the blue box in this figure that bendamustine plus rituximab plus a placebo, but that was the control arm, was compared to bendamustine plus rituximab plus acalabrutinib, the BTK inhibitor. Patients received 6 cycles of treatment over a 28-day cycle period, and then thereafter either received acalabrutinib maintenance for 2 years with rituximab or placebo with rituximab. And again, very interesting results showing that acalabrutinib plus bendamustine plus rituximab showed a significant improvement over the patients receiving bendamustine plus rituximab without acalabrutinib. And you can see that the median progression-free survival was 49 months for the control arm and 66 months for the patients receiving the BTK inhibitor. This has had additional follow-up subsequently. 2 questions were asked, and that is, over time, at the end of 2 years, are patients still remaining in remission? And number 2, what about the high-risk patients, particularly those with high Ki67 indexes or p53 mutations? And the follow-up data presented at ASH last year showed that the progression-free survival benefit was consistent across all of the different groups, including those with TP53 mutations, blastoid morphology, or a high index of proliferation. And as shown in the image, you can see that the acalabrutinib plus bendamustine rituximab arm, if you look at the purple at the top, the number of patients for whom MRD became positive was a very small group, in contrast to the patients who received bendamustine plus rituximab plus placebo, where there was actually a much more sizable group that were positive for MRD at the end of therapy. Again, all this to say that the progression-free survival was improved across all groups, and the depth of the response was greater and more durable. So as one looks then to see further steps and where one can take treatment next, the obvious next question addressed by the ENRICH trial was, do you need the chemotherapy, but could you get away with utilizing a BTK inhibitor plus rituximab in comparison to chemotherapy plus rituximab? So in this trial, institutions chose the initial chemotherapy that they wished, either R-bendamustine or R-CHOP. Once they had decided, they were then randomized to either receive that regimen over 6 cycles of time and then rituximab maintenance, as shown down the left of the image, or alternatively randomized to receive ibrutinib plus rituximab. And the interesting result from this study, with a median follow-up of around 4 years, showed that patients receiving ibrutinib rituximab had a superior progression-free survival of 65 months compared to the patients receiving standard R chemotherapy, where it was 42 months. Additional follow-up looked at the actual chemotherapy side of things and showed that the advantage was predominantly seen in comparison to the patients receiving R-CHOP. So you can see on the left, the green line are the R-CHOP treated patients, and they did significantly poorer than the patients receiving ibrutinib plus rituximab. In contrast, patients receiving bendamustine plus rituximab had a lot more similar difference in progression-free survival to those receiving ibrutinib rituximab. So I think clearly the benefit for the ibrutinib rituximab was over those receiving R-CHOP. This does not mean that ibrutinib rituximab doesn't have advantages over bendamustine rituximab, as the results still show a similar outcome, and obviously that is not a chemotherapy regimen and is better potentially tolerated. So the next steps thereafter have really been to see, can we further build on this chemo-free regimen? So I will show you two studies that was presented in the previous year that have really looked at bringing venetoclax, a further agent that could target the tumor cells in mantle cell lymphoma. So venetoclax, as most will know, targets BCL2. So here it was a regimen of acalabrutinib, venetoclax, and rituximab. It's a small study of only 21 patients. I'll draw your attention to the bar graphs in yellow in the middle. But the finding here that was very encouraging was that the overall response rate using these three agents was 100%. And you can see on the right-hand side at the Kaplan-Meier curves, if your eye goes to the blue curve, you can see that actually the progression-free survival for patients when deaths from infection was censored was outstanding. However, this study was done right in the middle of the pandemic, and they did have a number of deaths from COVID-19, and obviously that then made the progression-free survival, as shown in the purple, drop down, particularly at around the 18-month mark. I think the takeaway here is that this is a very effective therapy. However, this may make one a little more susceptible to infections, and in the middle of a pandemic, that obviously had significant risks. Additional data that informs that combination is the clinical trial of a regimen called BOVEN. And what this is zanubrutinib plus obinutuzumab plus venetoclax. So very similar principle of a BTK inhibitor, a CD20 antibody, and a BCL2 inhibitor. But this specifically focused on the high-risk patients that are TP53 mutated. Most will know that TP53 mutations are problematic when one gives chemotherapy because patients are not particularly sensitive to that. This regimen was very encouraging in that the study showed a very high response rate. If you look at the top on the right, the overall response rate was 96% with a complete response of 88%. Toxicities were manageable, and the 2-year progression-free survival in a high-risk patient that notoriously does very poorly was 72%, which was very encouraging. So while this was a relatively small study, this, I think, is a regimen that has a lot of promise, particularly in this population of patients. And finally, can we utilize a BTK inhibitor and a BCL2 inhibitor in the relapse circumstance? So this is after patients have received frontline therapy and have had disease progression. This was a randomized comparison of 134 patients who received ibrutinib alone compared to 134 patients who received ibrutinib plus venetoclax. And the ibrutinib venetoclax, shown in blue, showed a higher overall response rate and a higher complete response rate when compared to the ibrutinib plus placebo. So those were 82% compared to 74%, 54% compared to 32%. And encouragingly, as shown on the bottom, you could see that the median progression-free survival for the combination was 32 months compared to 22 months for patients receiving ibrutinib. So I think, again, the encouraging results here was that in the relapsed and refractory setting, this combination is highly effective. So what do I think over the last year we've learned and the takeaway messages that have really informed practice? Well, firstly, I think in diffuse large B-cell lymphoma, the addition of polatuzumab vedotin to the R-CHP regimen as frontline therapy has established that as a frontline combination. It improves the progression-free survival over R-CHOP chemotherapy, and it appears to be particularly active in the ABC subtype. Tafasitamab, the CD19 antibody in combination with lenalidomide, or loncastuximab, tesirine, the CD19 antibody drug conjugate, Both have been tested in diffuse large B-cell lymphoma and follicular lymphoma. Both show real promise, particularly in the relapsed refractory setting. Brentuximab vedotin, the CD30 antibody drug conjugate, in combination with lenalidomide and rituximab, has shown to be effective in relapsed diffuse large B-cell lymphoma, and that combination has an overall survival advantage over lenalidomide rituximab alone. And then in mantle cell lymphoma, a number of findings that have been very interesting. The addition of a BTK inhibitor to chemotherapy or immunotherapy in newly diagnosed patients substantially improves outcome. And this has called into question whether intensive chemotherapy, and particularly an autologous stem cell transplant, are really needed when a BTK inhibitor is added. The use of the BCL2 inhibitor venetoclax added to a BTK inhibitor and a CD20 antibody has been shown in 2 studies to be effective therapy for mantle cell lymphoma, and I think is particularly valuable in patients that have p53 mutated disease. And then thinking a little about patients who have relapsed and refractory mantle cell lymphoma, similarly, venetoclax plus ibrutinib has been shown to be beneficial and superior over using ibrutinib alone. So with that, I'll end, and thank you very much for your time and attention, and I'm pleased to have presented to you some really interesting data from the past year.